hear the welcome address from Professor Kato. Professor?
Yes, and everybody that very welcome. And today I'm very much looking for the Professor Hirohara talk because he's one of the sorry, he's one of the top endovascular neurosurgeon in Japan. Of course, Japanese endovascular a bit behind the other countries. This is our FDA program, I think. But I think he can talk the latest, the aneurysm treatment by endovascular. And the second talk, also I am very much expecting the German lady, the intraoperative neuromonitoring. So I thank you very much for everybody to join our YNS webinar. Thank you very much.
Thank you to Professor Kato for the support always. And I would now hand over the podium to Professor Ashikuma to introduce both our speaker and invite our speaker to start his lecture. Prof.
Thank you, Dr. Liu. So once again, thank you so much for inviting all of us for this amazing academic feast. I would like to, thank ACNS and Professor Kato for giving us this platform. So with this, today we have some great talks lined up. So I would like to invite our first speaker, who is Professor Masaru Hirohara. He's a professor in Department of Neurosurgery, Kurume University School of Medicine, Japan. He's going to talk about endovascular treatment for cerebral aneurysms. And I'm an endovascular surgeon, so I'm really looking forward to his talk. Endovascular treatment, as Professor Kato said, has evolved a lot. And I think, I don't think so Japan is slightly behind. I think they are at the forefront of every neurosurgical aspect and every neurosurgical specialty. So, and I say this because I was a fellow there and I've seen what they were doing like almost 15 years back. So I'm really looking forward to this talk. Professor Hirohara, over to you for this presentation.
Yeah. So, okay. Can you hear me? Can you hear my voice?
Yes, Prof.
Yes.
Okay. So, first of all, I have to say thank you very much for inviting me to your lecture. It's a very honor for me. And today I'm wait a minute. Today I'm talking about endovascular treatment for the cerebral aneurysms. And I'm living in the Fukuoka prefecture. It's a southern part of Japan, and this is a hospital. So I'm gonna start my lectures, and of course, everyone knows that the endovascular treatment for the cerebral aneurysm was started in 1970s. This is Professor 𝒂𝒑𝒂𝒏. He's a Russian. He is born in the Caucasus area, and so he is the Russian so the citizen, and he invented the detachable balloon with the founder of the 𝑣𝑖𝑑𝑒𝑜 Medical. And this balloon is mounted to the microcatheter, and so you inflate the balloon using the stiffer agent and put it out and detach it. So this is he published the many cases of the using this balloon for the cerebral vascular disease, and majority of cases was the parent arterial occlusion, but here he used this balloon for some aneurysm treatment. So, and so this balloon is not available now, but we used to use this balloon, and I have two experiences of the 1990 and 1991. This is a basal tip unruptured aneurysm treated with one balloon only, and another case I don't have only the operative record. It's a ruptured ICC2 aneurysms. So this case is aneurysms are too big, so we compare the balloon size. So we navigate the microcatheter into the bottom of the aneurysm. So use the coils use some coil and at the neck of the aneurysm, we inflate the balloon and detach it. So this is a very exciting treatment, but its indication is very narrow, and only a selected case can be treated with this disease. So everyone knows this is the 𝑣𝑖𝑑𝑒𝑜, Dr. 𝑣𝑖𝑑𝑒𝑜. He invents detachable coil, and this is 1991 JSNS special articles, and his original interest was not detachable coil, but electrothrombosis coil. So he tried to insert the coil into the aneurysm, and so he positive direct electric current is applied. So around the coil had the electrothrombosis could be occur, and finally he detached it. But unfortunately, this coil did not have ability to the thrombogenesis, but it's just detachable coils. So this is very simple. So we navigate the microcatheter into the aneurysm, and so using a coil to pack the coil. So the optimal indication was small neck and medium-sized dome aneurysm. On the contrary, the wide neck aneurysm was not good indication, because the coil is easily migrating to the parent artery, or larger giant thrombotic aneurysm. How much coil we can use, but maybe the 50, more than half patients show the recanalization and growth, and so to deal with this situation, we can advance many adjunctive techniques: double catheter, balloon neck remodeling, center assist for 𝑑𝒓𝒐𝒏 and interest. So I will show briefly. This is the first reported case is treated with double catheter. So this is a ruptured vaginal chip large aneurysm. So this is the on paper from the Toronto teams, I think so. So he navigated 2 microcatheter into the aneurysm, so two coils insert to spare prevents PCA bilateral PCA. And so this is so definitely useful. So this is my first case treated with a double catheter. This is a vaginal tip, the ruptured, acute ruptured aneurysm. Neck was 7 millimeter, and the depth dome was 5 millimeters. So we have to use less than 5 millimeter coil. So of course, the coil is not so fitted to the aneurysm wall. So we navigate 2 microcatheter into the aneurysm, and so 2 coils, forward 3, so to insert the entangling the 2 coils and create the frame, and after that we continue insert the coils. It's post-operative view. I think it's a very good result. This is another case. This ruptured 𝑎𝑐𝑜N aneurysms. This is agriform aneurysms. This is the left A1, A2, 𝑎𝑐𝑜N, and right A1. So this patient did not have a right A1, so we have to spare the everything. So beyond this line, only beyond this line we have to insert a coil. So we use a double catheter and 2 coils, and so create the frame, maybe just this line. So after that we continue the coiling. So the at least a rupture point will be occluded. So this is I think it's not so bad result. This is another case of the acute rupture 𝑎𝑐𝑜N aneurysm. So this, if we can use the same, it's not difficult, but in the acute stage, in Japan, the neck bridge stent is not available. It's acute cases, so you have to use without balloon. So we navigate the 2 microcatheters and the 2 coils and create a frame, and after that we continue the packing into the aneurysm. It's a post-operative use. Aneurysm is gone. It's not so bad, and so but double catheter or multiple catheter techniques definitely work, but it's some limitations. So we have the advanced many of device, including balloon, neck ring balloons. We have many companies neck ring balloon are available in Japan now. And 2010, we neck stent was available in Japan, and also 2016, it's flow diverter stent was came, and finally we have the web intracircular device. It is very fascinating one. And I talk is this is a 1997. Dr. Jack Morris very important paper. So he used the first reported case of the aneurysm, cerebral aneurysm treated with the balloon neck 𝑑𝒓𝒐𝒏. He navigates a micropattern at the neck of the aneurysm, and another microcatheter inserted into the aneurysm. So when he inserts the coils, so he inflate the balloon, so prevents the coil coming out to the parent artery. So it's a very nice use. So this balloon is very flexible. We can use every aneurysm. So it's MCA, PCA, like everywhere we can use it. It's this balloons, and this is the whole case. This is a good indication for the neck 𝑑𝒓𝒐𝒏 because so we inflate the balloon, just inflate balloon, so the spare, the neck is covered with the balloon. But how about this case? This case is the neck is mounted to bilateral PCA, so we have to two balloon into the two balloon from vaginal to the bilateral PCA. So the inflate the two balloon, and so you have to insert the coil. And it's a kind of complicated. And so after that, the super complex balloon was available in Japan, available in the world. So this case is 𝑝𝑎𝑟𝑡 was here. So when we spare the original 𝑝𝑎𝑟𝑡, so we have to overinflate the balloon. So this is this balloon is very flexible. So we can use the balloon. So the balloon is herniated into the aneurysm itself. So balloon is covered. The balloon could be covered with the origin of the 𝑝𝑎𝑟𝑡. So after that, we use we insert the coils as much as possible. The aneurysm is gone. It's not bad. And this is another case. Is the 𝑝𝑎𝑟𝑡 aneurysm. This is IC and 𝑝𝑎𝑟𝑡. So the neck of the aneurysm was definitely 𝑝𝑎𝑟𝑡. This is not ICPC, 𝑝𝑎𝑟𝑡 aneurysm. So we navigate the super compliant balloon. So you can identify the balloon is herniated everywhere. Origin of A1, M1, and at the neck of the aneurysm. So this will be very easily. So no stress. So we could spare everything. So just that we navigate the micro coil. That's it. So this is very good. But balloon itself has some limitation. This is the IC M1 MCA aneurysms could be treated with the balloon. The origin of the temporal artery was origin at the neck of the aneurysm. So we navigate the balloon and herniate the balloon and insert the coil. So after that, so we deflate the balloon, and the coil is only into the aneurysm only. But a few seconds after the detached, so the coil is protruded to the origin of anterior temporal artery. So this is so we after we deflate the balloon and detach the coil. So after that, the coil sometimes coil is moving to the parent artery. So it's not good, and it's a limitation of the balloon 𝑑𝒓𝒐𝒏. And after from 2010, the neck stent was available in Japan. So first, Enterprise and Johnson & Johnson Enterprise are available in Japan. So this is my first case. This patient treated with embolization, so maybe 5 or 6 years ago, but the patient aneurysm was large, so the recurrence, we can identify the recurrence of the aneurysm. So we put the stent from the IC at the neck of the aneurysm, and so neck coil. So the coil. So after that, maybe the 12 or 30 years have passed since I treated this patient. So this patient did not show any the recognitions. And so now we can use many types of the stent, the laser cut stent, braid stent. Laser cut stent is made from the metal tube, and cut the metal tube, and so and this is the with the stent. And on the other hand, the braid stent is the braids the stent from the wire. And so this is we can use now the Enterprise and Neuromonitoring and 𝑣𝑖𝑑𝑒𝑜 is available in Japan. And this is the original type of the Enterprise and Neurohome. This is almost same form of the vagal chip aneurysm. So we this is a wide neck aneurysm, so we have to use a stent. So this is put a stent and from here and from the right CCA to the vagal artery. So we need to cover the whole neck. So at the neck we push the stent a little. So it look like so not bad, but we confirm the POMVM CTs. So closed cell stent we push more too much push it. So stent is kinky. And on the other hand, the open cell stent is never kink, but the stent itself is strap itself is produced into the animal dome. I think it's but it's the clinical. It's not there's no problems, and we could coil and it's gone. It's not bad, but the original type of the stent is have some the limitation. And after so these stents are the renewals, and so you can use the Neuromonitoring stent. This is a very good stent, and this stent could be used from the 𝑠10 very small microcatheter. This is case 𝑎𝑐ON aneurysms, and so we have to. This is a very wide neck aneurysm, so we have to use a stent. So it's so we put the navigate the microcatheter into the from left A1 to left A2, and so another microcatheter insert into the aneurysm. So then we put the stent, Neurohome stent. This stent is very position is very easy. So you just unsheath the stent, and it's a stent is spreads automatically. So we don't have to worry about the position of the stent. So after that, so we use the coils as much as possible. And so 1 year later, so the aneurysm is gone. It's not bad. So it's good. And this is another case of the distal MC aneurysm, the two aneurysms there. So we decided to use the stent, one stent and two coils. And so we put the sorry. We put the microcatheter here, and the stent, half of the stent opens, and the coil D, and pull out this catheter, and so navigate the proximal aneurysm into the proximal aneurysm, and the stent was deployed, and it's called the post-operative use, and this is 2 years after treatment. So the result is not so bad. So, yes, and I'll show you the video of this is MC aneurysm treated with sorry, this is a kind of wide neck aneurysm, and so okay, so this is guide wire, microcatheter navigate into the inferior trunk of the MCN, and this is a fourth stent. So another catheter was introduced into the dome. So it's an yeah. Then we put the Neurohome stent, 3x20 stent. So it's put the stent from the inferior trunk to the M1. It's just the unsheath the stent, the microcatheter. The stent is automatically open. So after that, we navigate the microcatheter into the aneurysm. So two catheters are inside in the aneurysm. So we start the coiling. So So this is the neck was remodeling by the stent, so nothing is the migrating to the parent artery. So after that we use we insert the cords as much as possible. And that's it. So this is it's open cell stent. Open cell stent is a very good application and easy to use, easy to everywhere, and it's a good stent. But we have another kind of the braided stent. Its advantage is mesh density. The metal coverage rate is higher than the neurohome. Atlas is 20%, only 20% of the metal coverage rate, and but the 28%. So the pipeline, the flow data stent has 35%. So to compare with the pipeline, the metal coverage rate is lower, but the higher than the braid stent. So this is a case in the IC2 so it's we navigate the 𝑣𝑖𝑑𝑒𝑜 stent. After that, we perform the angiography. So the contrast medium in the aneurysm the pooled because it's this neck of the aneurysm was covered with a stent. After that, so we navigate the coil as much as possible. So this is very good for the proximal ICA aneurysms. I use this stent for all ICA aneurysms. And this is another case. It's ruptured by vertebral dissection aneurysms. And the pica is originated from the bottom of the dissection. So of course we have to spare the origin of the pica. So we decide to use the 5.5 millimeters stent. We put a stent, and the origin of the pica is covered with the stent itself. After that, we navigate the coil. So the post-operative view, so we can spare the pica. And 1 year for DSS means the aneurysm is gone, and the pica is it's a patent, and the aneurysm is gone. So I think this aneurysm could be cured. It's a good thing. So because this is a very small P1 aneurysm and acute ruptured case, it's aneurysm only 1 millimeter. So coil embolization is I think it's difficult. So we put one braided stent, 𝑣𝑖𝑑𝑒𝑜 junior, and so after put the stent, and so we do the angiography. So aneurysm the contrast medium into the aneurysm is reduced, but still have. So we don't have a confidence that this is prevents a rupture. So we use 1 millimeter coil, diameter coil. Only one loop could be inside, enter into the aneurysm. So we do the angiography again, and so aneurysm is gone. But the rest of this coil, so we cannot insert the whole coil into the very small aneurysm. So we put a second stent, so 𝑣𝑖𝑑𝑒𝑜 junior, and so rest of this part of the existed between the first and second stent, and this is 1 year followed. So the aneurysm is gone, and the PCA is patent. I think aneurysm could be cured. This is another case, and this is also the PCA ruptured aneurysm. So we put a 3 stent, the 𝑣𝑖𝑑𝑒𝑜 junior stent, and so immediately after the stenting, aneurysm is still gone, but later, so maybe the one month, maybe almost 1 month, the aneurysm is shrinkage. So this patient has 2 years has passed since we did, but never re-ruptured. I think this aneurysm could be controlled by the 3 stent. I show you this the stent cases. This is a very wide neck and shallow dome aneurysms, and this is those bilateral VA is not so big. So we put the coil into the aneurysm, then put the stent, this stent, ellipse junior stent. So covered with the neck mechanisms, and so we use the coil, but this part was not could not cover with the stent. So the coil is protruding the left piece. So we navigate the second micro catheter and so two coils entangling the coil, and so prevents the coil is protrude to the left PCA, and so we could insert the coil as much as possible, and so detachable and the stent and more coils, and we can insert the coil as much as possible, as usual. This is post-op. Okay, so this is the followed MRI showing this, so the aneurysm is gone. So maybe the 1 year followed is the aneurysm is good. It could be treated. So now we have put the stent, but we just put the stent, but there's lots of variation of the modified stent acid coding. So this including the T-stent, horizontal stent or half T-stent. Half T-stent is like that, and so T-stent. T-stent is one stent is this econ management. One stent is from left A1 to the left A2. The another one is left A2, right A2 is here. So this is the T stent, and this is another case of Y stent. So one stent has left B, left A2 to left A2 to A1. Another one is left right A2 to A1. So this is some kind of the modification. So this shows that this is a IC-𝑝𝑐𝑜N, the fetal type 𝑝𝑐ON. So we have to spare the 𝑝𝑐ON. So we put the stent around here, and so like here. So we put a stent, and the stent is covered with the origin of the P1 and the pica and 𝑝𝑐ON. So we could coil as much as possible. And this is 1 year followed. The aneurysm is gone. 𝑝𝑐ON patent. 𝑝𝑐ON patent. This is on another case is also have fetal type 𝑝𝑐ON. So we navigate the microcatheter and the stent was there from the here to here, and insert the coil as much as possible. So everything is a 𝑝𝑐ON patent, then some aneurysm is gone. So another. So this is a Y stent. Y stent is, I think it's this is a typical case. It's a needed Y stent. This is a budget management. So neck is too broad, so we have to spare the bilateral PCA. So we put the one stent from the left P to P1 to the vaginal, and then so we navigate the microcatheter from the vaginal to the right P1. So the second stent was deployed, and then from the we navigate another microcatheter into the dome, and so Y stent and the double catheter. So and after that we insert the coil as much as possible. This is 2 years followed. It's management is stable. It's a very good. This is the only option we can treat it with endovascular. This is another case with econ management. So this is puts the microcatheter from the here, right A2 and the econ. Then we navigate the microcatheter to the right ACN and put another stent and to Y here lesion. So it's just after that we insert the coil. I think it's a good result. This is another case of the IC-𝑝𝑐ON aneurysm. So we navigate the microcatheter from the to the 𝑝𝑐ON PCA. So and this is microcatheter. And so another catheter is insert the dome, and so we put one stent from the 𝑝𝑐ON to the proximal ICA. Then another stent was deployed from the distal ICA to the proximal ICA. So this is the Y stenting. Everything is the spare, the covered with the stent. So you put the cords as much as possible. It's a post-operative use, and this is a I should show you the video. So, so to navigate the microcatheter into the PCA, PCON PCAs, we have to turn the microcatheter into the anime dome. So we use the marathon, very soft and the soft catheter. Then so we change the wire exchange, and so to navigate the microcatheter to put the stent. And another microcatheter was inserted into the anime dome. So we put the neuroform atlas stent. So we start the deploy the stent from the PCA to the proximal ICA. So after that, we navigate another microcatheter into the distal ICA, passing through the stent strap. This is stent strap, so we can penetrate the stent. So another stent was deployed from the proximal distal ICA to the proximal ICA. This is another open cell stent. It's very easy to open, and so worry about the position. So that everything is covered with stent, so we put the navigator inside the coil as much as possible. So we can use the main coil as much as possible, and the post-operative view, the aneurysm is gone. This is a YNS photo. So it's not visualized, and we can control this aneurysm. So so we have maybe the Y stent have some chance of the thromboembolic complications, but I have treated 20 cases of the Y stenting. So I prefer my preferred stent is Atlas, two Atlas. This is the operation is very good, so we use two Atlas. So from my small experience, I have no experience with the ischemic complications, and antiplatelet therapy that ended the 1 year after. So just same, almost same as the regular stenting. So finally, we have the flow diverter stent and the intrasaccular aneurysm device. This is a pipeline and the thread, and then we put the pipeline and thread at the neck of the aneurysm. That's it. So 1 year followed DSS showing the aneurysm is gone. So we could be cured this type of aneurysm. This is the web with the intersaccular device. It puts a device into the aneurysm. We have just started using this, and I don't have so many cases, but it's just only a selective case, but it's very good option with the coil. I know. So this is I show you some cases. This recent case is a symptomatic pan-ophthalmic failure and right cavernous IC aneurysm, large aneurysm. So this is the 3DSA. So to the flow diverter stent, the choice of the stent diameter and length is very important. So we have to check the diameter of the proximal and distal side of azimuth. So usually the aneurysm is getting bigger, and so the artery is compressed and deformed the form. So we check everything, and also we have to check the length of the need stent. So we decide the stent. So after that, we put the stent, and we put the stent just after the stent deployed the aneurysm, the contrast medium into the aneurysm, the pool. So it's a good, we call it eclipse sign. It's a good sign for the complete emboli cure the mural. But after stenting, we have to do cone-beam CT to confirm the stent, the position. This is the distal end of the stent is and the ICU wall has a gap, so this is not good. So this is this may be the cause of the cerebral complications. So we put the PTA. We have to PTA and answer. So this is I show you the small video and the animals. And so we navigate the microcatheter to the maybe the M1 and the stent coming, stent here. That's we put the stent from here to here. So but we open the stent the more distally and bring back to the this is started here and just put a stent and DSA showing the reduce the control medium is the reduce. That's you have to put the PTA. That's it. So this is possible. So maybe the 20 days after treatment, the anemia is on the MRA. The anemia is gone, and the MRA and MRA and the MRI is showing the anemia is gone, always gone. So and maybe just 3 or 4 months after the treatment, we have the patient symptoms, all symptoms, or the cure. So finally, we have the web. This is a case of the. I checked the before and after the stent available. So 2009, we don't have a stent yet. So it's only 100 cases. I have treated 100 cases, and 30% was just a simple technique. Another country was some kind of adjunct technique. But balloon was frequently used. But 2021, it's of course, everything stent and flow diverter, everything is available. So we don't use balloon so much cases. The stent was reported half 50%, more than 50% patient treated with the stent, and so this is a 60 animals. This is this 60 animals has an indication of the flow diverter stent. So the larger animals we can use we use almost all cases the flow diverter, but from 5 to 10 millimeter animals, we can use the flow diverter or stent acid coiling. So, I prefer the stent acid coiling because flow diverter stent is good, but it's after the treatment, almost all cases the control medium is into the stent animal is still open. So, and this is maybe put a stent and 1 or 2 or 3 years. Maybe the 90% of patients could be cured the anemia, but on the contrary, it's less than 10%, a few percent of the patients did not have the cured anemia. So after that case, we cannot use the coil because the flow diverter stent is a mesh is very small, and so we have to put another flow diverter stent. So as a medium size aneurysm, we at this moment I prefer the stent acid coiling. The final, this is almost my presentation, and it was this is the web which we have recently we can use the stent web. This is I should show you the videos, and this is almost this is I'm sorry. The microcatheter already is inside in the animals, and this is web with comings, and just the pull the microcatheter and open the this is a web. So just putting back the microcatheter. That is, and after that, the animals as means almost the bone. It is this then the detach, just detach. This is very easy and very easy, but it took 20 or 30 minutes to only finish the procedure. So and it's I think but indications this is not this is only as a terminal type aneurysms and with some limitation, but it works. And so you're gonna stop finish my presentation. The Endovascular treatment of cerebral aneurysms started in 1970, and several attempts have been made for the but not satisfactory results have been obtained. So, but recently, technological advancement is make it possible the majority of cerebral aneurysms treated with endovascular treatments, endovascular. But however, the neck being the alternative surgical process still careful selection and it's mandatory for the improve the patient outcome. And thank you for your attention. Anybody say?
Yes, Professor. We can hear you.
Yeah. I finish. I finish.
Okay, thanks.
Thank you for the presentation.
So Ashish?
Yeah, thank you, Professor Hirohata. I would just, I saw, I have, that was an excellent presentation. Actually, you covered everything which is usually in these days done for ruptured and unruptured aneurysm, including simple coiling, balloon-assisted coiling, stent-assisted coiling, and flow diversion, whether it is intrasaccular or extrasaccular flow diversion. I just wanted to see, like, there are a lot of patients where there were ruptured aneurysms and stents were deployed. So what's your philosophy for treating ruptured aneurysm with stents? Because you have to load them with antiplatelet agents, so not two antiplatelet agents. So how do you manage? What's your loading? What's your medical management of these patients in an acute rupture?
Yeah, so first of all, so the stent is not available in Japan for the ruptured cases. So of course we have to use sometimes some occasions, but first we try to the coiling without stent. But some cases we cannot do, so we put the stent. So that moment we could, of course, we loading the antiplatelet. We use the ACN, the prasugrel, 20 milligram prasugrel and 100 milligram aspirin from the gastric tube. And we, of course, we check the ACT. No, I'm sorry, verify now. PRU and ARU, check it, and maybe. So as you know, the Oriental East Asia, the people have many of the many hyporesponder with the P2Y12 inhibitor, but FN prasugrel has only a few percent of the people have showing the hyporesponders, and I think it's not too difficult, and not so. So that kind of problem is the reducing, and so my answer is I use when I use the stent and we prasugrel 20 milligram prasugrel and 100 aspirin just before the stent.
And how many hours before the procedure do you load the patients on both the blood thinners?
Sorry.
The rupture. How many hours before the surgery you keep them on the blood thinners? How many hours before you load them, or you give prasugrel? When do you give prasugrel? Before the surgery?
Just before the stenting. We loading the prasugrel, and the end of the session. So when we finish the treatment, we check the PRU, and so if the drug is not efficient, so it aids another kind of the antiplatelet, like cilostazol or something.
Thank you, Professor Hirohata. I think this is very important for anyone who is starting in endovascular neurosurgery. to see to do the ruptured cases with stent-assisted coiling. We essentially like to avoid that situation at all costs. But as Professor Hirohata said, there will be some situations where you have to do it, and then you should load the patients on the antiplatelet agents as close to the deployment of the stent. So here we do it like our practice is to do it like 3 hours before the surgery. So if suppose we are planning the surgery at 9 a.m. on the same morning, say around 6 a.m. we load the patients on aspirin, and we use clopidogrel here, Professor. So we used clopidogrel and aspirin and load them just 3 hours before, so that by the time intubation is done and basic runs are done, it's already in circulation. But we really try to avoid antiplatelet agents. And as neurosurgeons, I think because we have other expertise of clipping, would like to, especially for anterior circulations, we would like to offer that treatment. But I would like to know, in your cases, how do you decide? Do you discuss with the open vascular surgery as well, or do you do it yourself? How it works at your place, Professor?
Yeah, so in my institutions, the majority, maybe the 90% of the patient treated with endovascular, and of course, only as a MCA aneurysm could be to clipping. And if the more than 2 stents it's mandatory for the treatment, we select the clipping. But even if the MCA aneurysm could be treated with 1 stent, we perform the endovascular. Of course, the patient, every patient needs endovascular because nobody wants to open the skull if possible. So my answer is maybe my department, our department is with 90% of the aneurysm treated with endovascular.
Thank you, Professor. We here will discuss really with the patient's family, and unless it's a posterior circulation aneurysm, then patient usually goes for open surgery. But in your situation, in your personal experience, Professor, like patients who has intraparenchymal clot or who have a little bit of small bleed associated with the hemorrhage, and when you load them with tubular thinners, the problem is you expect in future, next 24 to 48 hours, that hematoma can expand. So how do you manage that? And the second question is, how do you manage the EVD in these patients if they have hydrocephalus?
Yeah, so thank you very much for it. It's a very important question, and of course, it's sometimes so so we have faced the hematoma is growing. So this is maybe the Sylvian hematoma and the interhemistic hematoma patient with. So that is sometimes after the procedure, the hematoma is getting bigger, and it's about. I think it's not so common. So I have the few experience of the craniotomy and hematoma evacuation, but very limited cases. And recently we don't have such kind of case. We don't know. Maybe last 10 years I don't experience that kind of cases. And so, but maybe so of course I didn't say it. Of course the rupture is a hematoma, ICH. So of course we could clipping. We could transfer the clipping and the hematoma evacuation, and maybe sometimes we external decompressions and so. And I forgot second question is
EVD. So if suppose patient has a hydrocephalus, that's an important point, because we have seen many complications when somebody has just come out of coiling and somebody tried to put a EVD in. So what's your time? I mean.
So maybe I think it's the majority of the cases. Firstly, is under the general anesthesia. So we put the spinal drainage just before the surgery open and started surgery, and so sometimes we have to perform the ventricular drainage, but I think it's not so difficult, so we don't stop the antiplatelet. We don't stop it. Just dual antiplatelet, and just to put the spine ventricular drainage we done. I think it's not so complication. We don't face many complications with so the spine, even if we have to use the ventricular drainage.
Yeah, because I know there have been some cases where EVD insertion has been done after surgery, and that has caused more problems because the ACT was really high, and somebody just did an EVD within 3 hours of the coiling procedure.
Yes,
and that
yes,
caused
yeah, of course, it's a problem. So we don't want to do the ventricular drainage after treatment, after surgery.
Yeah.
Nobody.
So our practice is basically to do the EVD before, like if the patient comes in the night, one day before, or one night before, or late in the night, just before the surgery, at least 3-4 hours, because when you heparinize for the coiling, so if there's an EVD tract hematoma, that can expand as well. So just to check, we do a CT after the EVD, just make sure there's no big hematoma. It allows us to change the dose of heparin when we are actually doing the procedure afterwards. Thank you so much.
Thank you.
Sorry, you were saying something.
No. Thank you very much for the good comment. Thank you very much.
Thank you. I would like to. No problem. No. Your English is very good, Professor. I understood. We all understood that. Thank you for an excellent presentation.
Thank you.
Professor 𝑣𝑖𝑧𝒂𝒏, do you have any questions and comments on this presentation?
Professor Hirohata, thank you very much for excellent presentation. I think it's great. So I remember a couple of years ago, there was the main criticism toward the for the diverters was focused on absence of long-term results of this procedure. So at that time, the procedure was really young, maybe it was 2 or 3 years. Now we have at least 7-8 years experience. How can you characterize the long-term results in patients with the flow diverters? What kind of complication they have, or are there some threats for these patients? What was your experience?
So thank you very much for the very important questions. Of course, we started when we started the pipe the flow diverter. I'm kind of skeptical for the long-term result, but now we have used 5 or 6 years have passed. We started using them, and the result is very good. Even 1 year followed DSH, and it is gone. I have never experienced after that, and it is declinized. The growth declines. I have never faced that case. So this the material. Once aneurysm is gone, I'm now at least I believe I could cure that this aneurysm. Of course, maybe a few percent of patients did not show the complete obliteration of the aneurysm. It's a kind of very problem. All we can do is just put another flow diverter. That's it. And even if you use a 2 or 3 stents, but some patients have the stale aneurysm visualized, and sometimes it's growing. Maybe I think it's a thrombose aneurysm, or the blood flow from the vasovasorum or something, and so that's kind of cases. We cannot control this. We have to sacrifice ICA, and sometimes I have a few cases of take it out the aneurysm. So. So the complication rate is very low, I think, very low. So this material, but the result is satisfactory. So maybe the 80%, 80, almost maybe 80 to 90% patients show the cure the aneurysm, could cure the aneurysm, but less than the 10%, less than 10% the patients who did not show the complete obliteration. It's a very problem. So all we can do is put another stent. But the operation is not so good. So it's a kind of very problem. That's we cannot we can recognize which one is hard to the cured, or which one is easy to cure? I don't know. I don't select it before the surgery.
Okay. Thank you. And one more question. How do you think? How do you see the future of revascularizing surgery? Will it be replaced by endovascular procedures completely, or there will be some segment just for bypass surgery, open bypass surgery in the future?
Of course. So neck clipping itself is, I think it's a very limited patient will be the choice of the treatment, but the bypass surgery is very important. So we are in neurosurgeons. We can bypass every kind of the bypass we can do. It's very helpful. Sometimes we have to sacrifice the parent artery, and so bypass surgery is a very important for from now to maybe forever. So, but neck clipping itself is I think its number is decreased. I think it's in the European countries. It's clipping is maybe very limited case treated with clipping. I'm thinking. I believe so.
Thank you. I asked this question to show my younger colleagues that it's very important for them to participate the hands-on courses, to be trained very well to put microanastomosis. It's still important.
Thank
you very much. Thank you very much.
Professor Irian, do you have any comments on the presentation?
Ashish, good morning to you here in Toronto. And, good afternoon and good evening to all colleagues. Hirohata Sensei, arigatou gozaimasu. It's a wonderful talk. You introduced us history and then the steps of development all the way to here. But then I fall short of any comment I can have when I followed Professor Wozniak from Ukraine, who joined us today, and I'm so happy to see him back. Yes, I do realize that endovascular is taking over, and I see that in your practice as well, over 90% of the cases you're treating your patients by means of endovascular. But I do believe there's always going to be a case for open surgery, not necessarily most of the cases clipping, but the need and the requirements for all of us to remain up to date with skills of bypassing. It is not always the endovascular treatment of disorders that we would require to use those. It is skull base or tumors that would require to have those skills up to date. I cannot move forward with any comments because Dr. Kumar here is a well-skillful endovascular surgeon, so I left to him all the comments. So thank you, Hirohata Sensei. Arigatou gozaimasu.
Thank you so much. Professor Kato?
Okay, thanks so much. So Hirohata Sensei, I just want to ask one question back to the Professor Alexander question, because as for the flow diverter is very fantastic, the treatment in the very near future, I think. So do you have any differences, the size of the aneurysm when you use the flow diverter? If the size is smaller, the easy to be the embolize of the aneurysm, because we are very much concerned about the rupture in the future for the unruptured case. So I think can we estimate, because the large type of the larger size of the aneurysm, such as a 15 or 2 centimeter size, so how long does it take to complete observation? And also the second question is how long the patient needs anticoagulant after flow diverter?
Thank you very much for the good questions. Thank you very much. So of course, as you said, the size bigger, so bigger, the complete the obliterations have more time. So at least you have to wait one year after. So So, so I usually the result was the estimate the 1 year. So the 1 year after the 1 year, maybe the 80%, maybe the giant aneurysm 70 or 50, 60% had obtained the complete embolization, and sometimes we so large aneurysm, so we put the 2 or 3 overlap stent, or so because anyways, one stent is not enough for the flow diverting effect. So recently, as you know, recently we can use the multiple flow diverter is available in Japan. So I usually the large or giant aneurysm, so especially giant aneurysm, we put the two, at least 2 stents, overlapping 2 stents. So I think it's a better or not better. I don't know that it's better or not, but all I can do is just put a stent, or sometimes we put a coiling, and so coiling and the flow diverter stent is a very good option. So maybe we put a coil. Maybe almost all cases showed the complete obliteration after 1 year, 1 or 2 years. It's of course some limitation with the who pays the money for the coil, and so it's an economic program, but we put a coil. It's a one resolution. And how long? So the antiplatelet, I use a dual antiplatelet 1 year. After that, we do the angiography, and the aneurysm is gone. So we reducing the antiplatelet, and so 6 to 1 year. So we off the all we off the all antiplatelet. Maybe some doctors are using the aspirin for forever, but from my experience, I have never shown the case of the delayed thromboembolic complication. Now I stopped the antiplatelet 2 years.
Thanks so much.
Thank you so much, Professor Hirohata. I see there is question. One question in the chat box. Professor Pirzad wants to ask your advice for conservative management of aneurysms. So how do you manage them conservatively? When do you not operate on aneurysms?
So I mean, the conservative aneurysm is just following. It's a very difficult question, and so just I think so. Just follow the MR or CT or something, and so aneurysm is getting bigger, and so of course it's a more chance of the bleeding. So we ask the patient to send. I think I should treat with it, but the contact management is very difficult, and just follow. And of course, the stop. If the patient is a smoker, we offer them the quit the smoking. And so, of course, the patient has a hypertension. So we use the antihypertensive drug and to control the blood pressure. But so I can do that. That's all I can do. I think it's a very difficult question. My answer is not so correct. I'm sorry, but that's my answer.
No, Professor, that's an excellent answer. What's your minimum? What's your size of treatment? Like, every institute, every person, every surgeon has a different threshold for treating aneurysms. 3 millimeters, 4 millimeters, 5 millimeters. I know Japan has a very high incidence of subarachnoid hemorrhage, so their incidence is completely different from the world incidence of SAH, and this is done. There's a meta-analysis on that Japan and Finland have very high rates of rupture rate. So what is your cutoff for treatment and any size?
Yeah, well, size is of course one of the key factors besides the indication. Maybe so from the guideline of the Japanese guidelines, 5 millimeter, some kind something 5 millimeter, more than 5 millimeter is indicated for the treatment, or some kind of ACOM and budgetary aneurysm, so that has a more chance of the rupture rate of the maybe higher. So even if the ACOM aneurysm, maybe if the aneurysm is more larger than 3 millimeters, I offer the patients. So how about the surgical intervention? How about those? I think so. Size and location, and so of course the family history and the patient background is also important.
Thank you so much. I see Dr. Abile has a question. He has his hand raised. Dr. Abile.
Hello, can you hear me?
Yes, we can hear you.
Yeah, hello, dear colleagues. Thank you, Professor Hirohata, for such an interesting and informative talk. I'm a neurosurgeon from Kazakhstan. I have a few questions. You said that there are only limited cases for microsurgical treatment of aneurysms, and what are the indications in which cases you send patients for microsurgery or clipping? And second question is, how often do you use combined treatment strategy? For example, high flow bypass, and then when we must or we have to replace the ICA. And also the third question, and I hope the question is correct, but I understand that every case is selected individually, but however, what are indications, maybe at least main point indications for double catheter technique, stent assistant, and also balloon remodeling technique? Thank you.
Okay, thank you so much. So first question is, what kind of patient do we transfer to the open surgery? Okay, so I answered before. So MCN. So if the patient needs endovascular treatment, so I'm thinking about endovascular treatment, but that patient we have to use the two stent, it's Y stent or T stents. So we transfer, we say the patient use this animal should be treated with neck clipping. So and besides MCA, so another so patients needs and preference is endovascular. I treat the endovascular, even if you have to use a Y stent or T stent, half T stent, or whatever. So I try if technically we can technically we can do this, and we will do the I will do the endovascular. So the second question is how do you select the advanced techniques? And double catheter is so I can use every kind of case. So to insert microcatheter, one microcatheter to microcatheter doesn't matter about it. So of course, very small neck, and so we don't have to use any adjunctive technique. We select the single catheter, but maybe so double catheter we often use it, but it's one catheter, two catheters doesn't matter about it. So we select the double catheter very frequently, even if we use a stent. So another stent flow diverter is of course we have a guideline. So guidelines maybe so 5 millimeter. So the animal is 5 millimeter larger than 5 millimeter, or neck was larger than 4 millimeter. It indicates the stent. The flow diverter is more than 5 millimeter. The side wall aneurysm indicates the flow diverter. So basically, I decided as a guideline. It's my question and answer.
Thank you. Can I just add something? Does it matter the length of M1 segment? when you make decision about clipping or maybe endovascular
M1,
short or long M1 thing?
MR, I mean, I think it's MR genes have M1 bifurcation is not so difficult, but M1 is the perforator is the presence of perforator is some problem. So maybe my neurosurgeon open surgery group M1 is he don't want to do clipping. So how about he asked me anytime, so how about endovascular? So because even the short M1 or the short M1 aneurysm, so the M1 LSA aneurysm, so maybe the endovascular is more have less risk than clipping. I'm thinking about it. But so my neurosurgeon don't want to perform the M1 perforator analysis. They prefer one. Maybe it have some risk of the occlusion of the 𝑣𝑖𝑑𝑒𝑐𝑡 arteries. I'm sorry, my question answer is not okay. Sorry.
Thank you. Thank you. Thank you.
Now I see Dr. Sam has a question. He has his hands raised. Dr. Sam.
Hi, good evening, everyone. Thank you, Prof. Hirohata, for a very excellent lecture. Good evening, Prof. 𝑦𝑒𝑛𝑠 and Prof. Ashish. I would like to ask two questions. My first question would be for endovascular treatment, the recurrence rates are higher compared to microsurgical clipping. What is your regime or your routine, Prof, for repeating the angiogram? How often do you do it? How long do you do it for your patients? Or do you not use angiograms, or you use the magnetic resonance angiography, TOF, or contrast enhanced for this? So that is my first question. And my second question, since these flow diverters are getting more and more commonly used, what is your experience in terms of recurrence rates of aneurysms after being treated with these flow diverters, and how do you treat them after that? Thanks.
Okay, thank you very much. Thank you very much for the good question. So the first question is how could I am doing the following? I usually the MR followed MRA, and I only a week to stent acid coiling. After 1 year, we perform the angiography only one time. If we don't use the stent, just MRI, MRI following. So every 1 year, first my protocol, 3 months after the treatment, we one MRI. So the result is okay. Next is the 6 months after the treatment. After the 6 months, we put another MRI. It's okay. So every 1 year, we do the MRI. So that's it. So we don't want I don't want the angiography. To have risk of nobody want to receive the angiography. So I rarely select the angle. Even something happened on the MRI, we ask the patient to do the angiography. How about the angiography? This is my following. And second question is, I have never experienced the recurrence after the recurrence means the 1 year followed, 1 year DSA showing the aneurysm completely gone. After that, so aneurysm is the decard. That case I have never experienced it so far. Of course, sometimes the 1 year followed, the aneurysm still visualized. That kind of cases that we have. So we put maybe more 1 year following, and 2 years followed. They say have some the aneurysm flow. The only I can do is put another stent. That's it. Do a stent. No, so I'm just following. That's it.
Okay, thank you very much, Prof.
One of the tricks to do this is, and we follow the same year, we do MRI 3 months, 6 months every year. One of the things which we do after 1 year is sometimes the aneurysm is still patent. You stop one of the blood thinners, like from dual, you go to mono, single antiplatelet agent. So we stop, once you stop Plavix or once you stop Prasugrel, for example, and the patient is just on aspirin, that helps to thrombose it earlier. And sometimes you see that the next 3-6 months or 1 year MRI, that aneurysm which was still open after 1 year, it closes down after 2 years. If after 2 years it is still patent despite of single antiplatelet therapy, then as Professor said, I think the standard protocol is to put another flow diverter through the original flow diverter. So you double layer it, and then it closes over the period of time. Okay, thank you so much, Professor. I'd just like to ask anyone who has a question on this extremely important topic. I think we had a very good discussion today. Any other question from the panel? If not, I would like to thank you, Professor Hirohata. That was an excellent presentation, and we would now like to move on to our second presentation of the day. Thank you so much, Professor.
Thank you very much, sir.
So I would like to invite Professor Andrea Szeleny. She is a professor of intraoperative and clinical neurophysiology at the Department of Neurosurgery, 𝑣𝑖𝑑𝒓𝒐𝒏 University, Munich in Germany. Welcome, Professor. And she'll be talking on intraoperative neurophysiological monitoring in vascular neurosurgery, which is a very important topic. Those who do it for open vascular surgery, every surgery needs intraoperative neurophysiological monitoring. So we'd be really keen to hear her thoughts. I would like to invite her to start her presentation. Professor Szeleny, please, the floor is open for you.
Okay, thank you. Thank you for the kind invitation and the introductory words. And indeed, I'm in monitoring for quite a while. So let me see and share the image. So can you see the video or the presentation?
Yes, we can.
Okay, perfect. I will start actually, so those are my disclosure statements for the past 5 years. And I will give just a brief introduction into where we use intraoperative neuromonitoring in cerebrovascular diseases. Then I will start with a case demonstration and we'll go through the 2 methodologies I show there and also focus on the evidence why we should use this, or at least I think why we should use them. So cerebrovascular surgery actually is a very nice template. So in neurosurgery, clearly we focus on aneurysms and especially elective cases, but also the same applies if we look into CEA surgeries as well. But today I will focus on aneurysm cases. And actually they are very nice templates in tumor surgery. So it's basically the same results apply if it comes to vascular problems in tumor surgery. So we will start with a brief case report where I share real-time screen videos of an intraoperative neuromonitoring case. So that was a 55-year-old, otherwise healthy female patient, and she demonstrated with just occasional headaches. So that's why she received a brain MRI, where actually a big and large aneurysm already could be seen, as well as in the MRI imaging. Thus, she went for angiography, and the aneurysm was revealed. On the left side, you see the very complex structure in the conventional angiography, and on the right side, the 3D reconstruction. And clearly, this is always a case where aneurysm is being called for. Intraoperative monitoring is being called in. So this is already during the case, just to make you familiar what we see on the screen. So we always have, because that's within the setting, a free-running EMG, which is not really essential for the case, and an EEG. We have always a video of the surgical field. And here on the left lower side, you see, as it's a right-sided case, the left-sided median SEP, left-sided tibial SEP, and for control, the right-sided median SEP and the right-sided tibial SEPs. And in these two windows, you see the transcranial electric stimulation to elicit motor evoked potential. And also for the contralateral side, so the side of interest, and for the ipsilateral side for control. For the ipsilateral side, we always use one upper extremity and one lower extremity muscle. In this case, it's an interdigitorum 1 and the abductor hallucis. For the contralateral side, we have the template to use the contralateral biceps, extensor digitorum, and ID1 muscle, and the abductor hallucis only in cases of an ACOM-A or ACA aneurysm be at another muscle of the leg. So, and we are already in the middle of the case. So the aneurysm is exposed. It looks quite big and arteriosclerotic. And so here you see the median SEP just being running now the tibial SEPs, and here you see the MAPs. Usually we've set up the MAPs a way that they do not disturb the microdissection. So let me see. So then we come into the time where the first clip is being placed. And so here's the surgical field. These are the MAPs, the SEPs. We always make comments and we focus on the MAP. You see, this is real time. So the clip is being just placed in. Let me just show you this again. It's not a temporary clip, that was wrong. So this is the SEP, and here you see the MAP not disturbing any of the micro dissection. So now we are a little bit further. I had to speed it a little bit up. You see that there is already 2 clips in, and one is clipping the off the aneurysm, and the arteriosclerotic structure of the aneurysm is very nicely visible. So let's see what happened during that period. So focus on this one. We already see that we don't see a biceps MAP, so the technician stops and we just focus on the MAPs. And this is now real time, the clip is in, and you see within a couple of basically seconds, and every time the MAP is running, that we see a decrement and finally a loss of the contralateral MAPs. So we see that then, and this is real time, so it's neither speeded up or anything else. So just to follow this clip placement, we had a loss of the MAPs. Clearly, this is a situation which has to be resolved. And so at the same time, the surgeon decided then to place a temporary clip. And while doing this, we already see that we also have not only the MAP loss, but also a median SEP decrement. So here you can see the peripheral or high cervical spinal response. Let me go back again. And which is still to be recorded, clearly indicating that we do have a cortical problem. and that there is an ischemia pending. So now the temporary clip is placed and the aneurysm was clipped, and then the temporary clip is removed again. After a whole time of 12 minutes. And the moment so the clip was removed, you see a recovery of the median SEPs and also a very nice recovery of the MEPs. For control, we run the other side now, as we see that all potentials are being recovering, just to confirm that everything is all right. And then you see the median SEP recovering as well as the MEPs. What is quite interesting in this moment is that you see an increment of the SEP amplitudes as well as an increment of the MEP amplitudes. And actually, this is kind of a post-ischemic hyperexcitability. So in the end, the patient recovered nicely and all potentials were fine, and the clip and the aneurysm was clipped successfully, and there was no ischemia to be seen to follow the surgery. So the patient recovered and was, after surgery, in her normal speed and was discharged from hospital. So one methodology I presented and we always use are somatosensory evoked potentials. And so those are actually being activated at the peripheral median or tibial nerve. And the efferent fibers are conducting the activity along the dorsal column up to the cortex and the somatosensory area, where we can record the cortical evoked potential. So as you've seen, we saw a decrement and even a loss of the cortical SEP, and we see this related to either hypotonia, temporary clipping, kinking of vessel, or occlusion of the patent artery, or even with placing a retractor. So those are possibilities where we can see or might see SEP alteration. And what we do now, and what is a very nice and very valid use of somatosensory evoked potentials, is that we do know that there is a relation to the cortical cerebral blood flow. And we know when we lose the SEPs that there will be an infarct either at the cortical area or at the subcortical areas related to the lemniscal and somatosensory pathways. And we have to look into older data in order to understand why that is the case. So the nice thing about the SEPs is when it comes to the critical diminishing of the cortical blood flow below 18 milliliter per 100 gram brain parenchyma per minute, we see a close to linear alteration of the SEP amplitude. And this is indeed really actually fantastic. And the other good news is that we have a rather broad SEP functionality below the normal CBF, and just when it comes below the functional threshold, we see this SEP alteration. And as we all know, is that this is actually a relation of time. So there is time between the functional and the lesion threshold. And during surgery, we usually are within the first minutes of these lesion threshold and the functional threshold. So in this area, there's still the potential of full recovery and not developing into a full ischemia. Only if the absence of the SEP is too long and it's indicative that indeed we are below the lesion threshold and that the ischemia is inadvertently. So this is the first basic message that the SAP, if it comes to the cortical amplitude, has a close to linear relationship between the cerebral blood flow and the SAP amplitudes. And this is why we still need the SAPs in the operating room, as we all now tend to focus more on the motor evoked potential. So as the SAPs are generated within the gray matter, it is a prediction of the gray matter function related to the primary sensory area. But also, as we assess the efference for the subcortical pathway of the somatosensory pathway. Is there evidence that indeed it's really helpful? Indeed, there's it's already 10 years back, but anyhow, I think it's quite interesting to see. So 400 unruptured aneurysms being looked into and being monitored and assessed for SEPs. And if it comes to the anterior circulation, where the majority of the aneurysms being clipped, the majority of the patients did not show any SEP changes. And the amount of those patients who presented with a clinical stroke was less than 5%. So clearly, we do not detect all strokes. That's why later on we also look into the motor evoked potentials. But on the other hand, in those unfortunate patients with SEP changes, and if those being reversible, the likelihood to present with a clinical stroke is 80%. And in those with reversible and probably long-standing SEP changes, the clinical stroke might happen in up to 20%. The posterior circulation, as you all know, is a little bit more tricky, as we have very small vascular territories, and not all of them can be covered by the SAPs. So that's why in the posterior circulation, we might indeed see more clinical strokes not being detected by SAPs. So we have to think about adding auditory evoked potentials, maybe adding VEPs or motor evoked potentials. But for the anterior circulation, this is pretty much clear cut. In times of unchanged SEPs, the likelihood of a clinical stroke is less than 5%. In cases of SEP changes which are reversible, the likelihood of a clinical stroke is 80%. The sensitivity and specificity is accordingly with a very high specificity and a very high negative predictive value. And this paper is basically one standing for all other data, showing pretty much the same. The other methodology I presented were motor evoked potentials, which is a little bit more difficult, but not that difficult if you train and study those. So this is the transcranial elicited motor evoked potential, assessing the efference of the motor pathway within the capsula interna and the corticospinal tract. And we stimulate cortically, and actually that's wrong. We stimulate cortically and record from the muscles. So the motor evoked potentials do need a very high frequency stimulation, which was introduced in 1993 by Taniguchi when he was visiting the Schramm clinic in Bonn at that time. And the trick is that we need a very high frequency train of 5 being repeated every 0.5 to 1 second, which means that is the fastest assessment we do have in clinical neurophysiology intraoperatively. So we can have every second or every 2 seconds an update about the motor pathways. And this can be applied transcranially. That's what I demonstrated in the case series, or also with direct cortical stimulation, a little bit depending. This is from an old publication being published about more or less 15 years back. It is possible to subdurally slide the strip electrode over the motor cortex, clearly it's pretty difficult to read the parasagittal plane, but to reach the hand knob is rather easy. So one concern is always, can we do MEPs without disturbing microdissection? And indeed, yes, we can. And I like always to quote the nice publication by Laura Hemmer. She's in Chicago, and they looked into 220 craniotomy patients. And as she's an anesthetist, she has it much more in her hands as we do have as neurophysiologists. So in only 3% of the patient, there was disturbing movement. So the good news is in the majority of the patient, there was no movement disturbing the microdissection. And in those 7, it was nociceptive induced, so anesthesia was adjusted. And still there was feet movements in 5 patients. And in 4, it could be managed to record MEPs with adjustment of stimulation, but only in 1 patient. MEPs had to be aborted, which still means that when pausing the MEP, when pausing microdissection, MEPs can still be performed. So in her series, it was less than 0.5%. No MEPs were possible, and more or less that is the experience we do have. So it's in a very small proportion of MEPs where we cannot perform transcranial electric stimulation to elicit MEPs. As seen, and which is indeed the case, critical steps in aneurysm surgery are especially temporary vessel occlusion, which has very high likelihood of changes in transcranial and also gyrocortical elicited MEPs. Permanent clip on the aneurysm also has a chance of MEP changes, especially if this has been shown a very complex aneurysm with also a calcified base. But we also see changes after retractor placement, like an indirect compression, for example, of the ICA while dissecting the aneurysm. This is usually also related to some calcification and atherosclerotic plaques being spread away and within the just being like a calcified emboli. There might be changes due to the blood pressure, or also sometimes which came simply without really being noticed. Why we see some changes, we have to admit that as well. And if you look into the combination, as that was a case with an atherosclerotic aneurysm, there is a tendency that we, especially related to temporary vessel occlusion, see a little bit more changes, and also with repositioning of the permanent clip. But at that time, we still applied papaverine. Nowadays, we apply, if it comes to vasospasm, nimodipine. And clearly, the complexity of the aneurysm has an effect on alterations we do see in intraoperative neuromonitoring methodologies. The other thing which we are always interested in, do MEPs relate to the clinical outcome? And indeed, this is a study from Suzuki from Japan, also now more than 20 years back. And he was one of the first looking into the relation between MEP and the outcome, and especially ischemia being seen in the postoperative CT scan. And we do see that we have a permanent, if we do see permanent MEP losses, there's always a postoperative paresis with a very low tendency of recovery and an infarct, in this case affecting the internal capsule. In case of transient, in this series, it's been always less than 16 minutes. We might see transient or no postoperative deficits. So this is the good news. And very short transient changes of MEPs, there won't be any postoperative paresis or a very mild transient one. So the clear cut is if there are not any MEP losses, there should not be any severe motor deficit, and there should not be any lesion affecting the motor cortex or the corticospinal tract when looking into the CT or MRI scan. In case of reversible loss, and that's what we learned over the past 20 years, or irreversible MEP deterioration, we might see transient and also moderate or very slight motor deficits. And those also might be permanent, but they are usually very slight and don't lead to a very serious impairment of the patient. And we might see some edema affecting the corticospinal tract or the motor cortex, but no ischemia. And clearly, if there are reversible loss of MEPs, and irreversible means at least for 15, 20 minutes. So in these cases, we continue the MEP till the skin closure, really to see if there's any recovery. And also in those cases where we had a long transient loss, we usually continue till the skin closure to see whether the recovery was really true or if there is a second deterioration. And in those unfortunate patients where we see irreversible losses, we will have a severe and permanent motor deficit with barely any tendency to recover. And there will be a lesion and an ischemia affecting the motor cortex and the corticospinal tract. And Holdeffer presented a very nice paper where they looked into the likelihood of new motor deficits in relation to MEP alteration and losses. And so the MEP are modeled in a surrogate parameter model. And as you can see, the MEP alteration has a lower probability of a new motor deficit, whereas the MEP loss has a very high probability of a new motor deficit. When hooking up the cases and requesting neuromonitoring, clearly all in the team have to know about the vascular anatomy and about what to hook up and what is covering which is also to be translated as being said initially into tumor surgery. And so clearly for the anterior circulation, upper and lower extremity should be hooked up. For the MCA and ICA aneurysms, clearly always upper extremities, and for the ACA, ACOM-A, also lower extremities. The posterior circulation is a problem, as such as the vascular territories are very small and any ischemia might get undetected. Nevertheless, I usually also hook up upper and lower extremity SAPs. And corresponding to the SAPs, we hook up the MEP in MCA and ICA aneurysm, contralateral and ipsilateral upper extremity MEPs as being shown in the case, and adding more lower extremity muscles in case of ACA and ACOM-A aneurysms. So to sum up, SAPs indicate cortical ischemia, and they have a very high negative predictive value. So in my understanding, we have to use them. MEPs indicate, as they are more white matter function, especially subcortical ischemia, but also cortical one, but especially for subcortical ischemia. We can use transcranial electric stimulation, it's feasible. And lessons being learned in vascular surgery can be translated into tumor surgery. So all vascular injuries basically behave the same regardless of the type of surgery being involved. They also have a very high negative predictive value. Such, if it comes to SAP in cerebrovascular surgery, they have to use them simultaneously and in a supplementary use. If you work with neurologists, neurophysiologists, or yourself interested, there will be an educational course from the International Society of the Intraoperative Neuromonitoring, and that's going to take place in Athens in Greece. And this is a nice view from Munich, and I thank you for your listening.
Thank you, Professor Szeleny. This was an excellent talk on neurophysiology. The way we see this is as an absolute adjunct to a surgeon when we are doing it for any other indication like vascular or tumor surgeries. We use it for cervical spine surgery, for lumbar spine surgery. It never stops. It's for every other case. And it just gives a reassurance to us that our intraoperative steps are not causing any harm to the patients unknowingly, because knowingly, obviously, we don't want to do that. So thank you so much for your presentation. I just wanted to have a practical question in terms of temporary clipping. So when we are doing the temporary clipping and we are monitoring the MEPs and SCCPs, usually I see it as, unless some neurophysiologist tells me that there is a problem, I usually now try to continue the temporary clipping for more than 5 minutes or for more than 6 minutes. If there's no abnormal response or there's no drop in the SCCPs or MEPs in that, for that matter, how do you think its utility in temporary clipping versus when you have actually placed a permanent clip on the aneurysm? I know it's helpful in both regards, but what's your insights on its applicability to vascular neurosurgeons?
Well, we just perform continuous monitoring. So when a temporary clip is being placed, it's clearly announced within the operating room. And in our setup, it's that the anesthetist takes the time and announce every 2 minutes after the time has passed by. And we continue MEP and SCP. We just run through. And so clearly everybody is more alert, and there's even more alert when a temporary clip is being placed. And it's extremely useful, or it has to be, that the neurophysiological team knows what is going on in the operating field. So this is why it's very, very helpful to have the surgical view on our machines to see what is going on. And more recently, luckily we don't see a lot of changes during temporary and permanent clipping. So the one I shared with you was one of the few during the recent years. So we have a very skillful surgeon. But okay, we have to, I think they are helpful in both circumstances. And what I would also like to point out is that don't stop monitoring too early. So you might see changes also after the permanent clipping up to 15, 20 minutes later. So just, because people tend to, surgical colleagues and also neuromonitoring colleagues tend to say, okay, it's clipped, so we can wrap up the case. But we see delayed ischemia, so just continue till at least the dura closure, so that you have the 20 minutes for sure.
And I mean, we usually, when we start the skin, then we ask them to close. But yes, I mean, again, during temporary clipping, I find it very useful. But do you think, like, if suppose there are no changes, how confidently we can carry on with temporary clipping without removing the temporary clip and try to, like, for example, if you're dealing with a complex aneurysm and there are no changes on SCCPs and you have kept a temporary clip on, do you think the time is immaterial then, or you still cannot completely trust SCCPs when you're keeping the temporary clip on?
Well, okay, so if so MEPs and SCPs, so motor and somatosensory pathways, is what we can measure and assess. I have to say that in these surgeries, we also, the surgeon also use a microdoppler and the ICG angiography. And clearly, if the microdoppler signal is not sufficient, if you see a decrement or a diminish of the flow in the ICG, this is going to be taken care of. and despite if the SAPs or the MAPs are fine. So the SAPs and the MAPs tell us these two very important structures of motor and somatosensory pathways are fine. So there won't be any infarct related to that, but you still might have ischemia in other areas. And if you, and yes, this might not give such a severe disability as clearly a hemiparesis or a sensory syndrome. So all these is being implemented within the surgery. So if there are changes in microdoppler or ICG, clearly the surgeon has to react. And I know from Japanese colleagues that they tend to reopen every 5 minutes within the temporary clipping. And this, well, in our case, we try to have very short temporary clipping times, but it's not habit to reopen. I think this is a philosophy which is clearly to the surgeon's discretion.
Yes, thank you. But 5 minutes is usually the standard temporary clipping time, like 5 minutes on, 5 minutes off. Many surgeons do that. So it's just like when ICG and microdoppler will come into the picture when you have placed the permanent clip. When the temporary is on, basically you are completely reliable on either the time or on the input from the neurophysiology team. So I think what you are meaning is like is still it's a good habit to keep a 5 minutes on and off principle going despite everything is good on SACPs. So thank you so much. I would like to now ask Professor Wozniak for any comments on this talk on
Dr. Szeleny, thank you very much for excellent presentation. Actually, at the end you answered almost all my questions which I have during along your talk, but finally you answered almost everything. Thank you very much. Very practical, very really expert presentation, and really nowadays we cannot imagine our surgery, the vascular tumor surgery, without this tool in our OR. I would like to extend a little bit the topic to the AVM surgeries, cranial and spinal AVM surgeries. When the surgeon performs test occlusion of the feeding artery, how long do you wait? And what is more informative for you, somatosensory or motor sensory potential, to which do you rely on more when you check this test occlusion of the feeding arteries?
Okay, it's a very interesting question.
It's not easy. It's not easy.
No, it's not easy to. It's not easy to answer it in 1 minute. So one thing is that we have to separate in the interpretation cortical and spinal procedures.
Yes,
and if it
they're
comes,
different. Yes.
Yeah. So, and if it comes to cortical procedures, I usually rely on both only, and it depends where the AVM is located, clearly. So if it's more likely that it will have an alteration in the SAPs, we focus more on the SAPs. If it's more anterior or precentral located, we focus more on the MAPs. And I have the experience that we can have very delayed ischemia. So actually, yes, I prefer to have the test clip at least 5 to 10 minutes. But it's also the surgical approach. I would say it's something in between 5 to 10 minutes before then the final clip is, or the final clip is being placed. So if it comes to AVMs, spinal AVMs, we also usually run both, but clearly if it comes to the anterior spinal artery, we need MAPs. And then those are frequently being run, and it's also usually 5 to 10 minutes that we wait, although clearly 20, they might be delayed. It might take up to 20 minutes that we really see changes and alterations. But usually the surgeons are quite happy after 10 minutes. So.
Okay, thank you. Thank you very much. Thank
You're
you.
welcome.
Professor Irian, do you have any comments or questions?
Questions, not, but comments, yes. Doctor, yeah.
Right.
And hello, Dr. Szeleny. It's a wonderful presentation. There were a lot to learn. I do cooperate closely with our colleagues, although we started the practice of neuromonitoring very recently due to the infrastructure. My most recent practice was in Albania, so it's needless to say that it wasn't easy to set up a neurophysiological monitoring in our ORs. But I find it interesting always to go back to consider the importance of which one to use when we depend only on one. And I was following your table on how to monitor best the posterior circulation. And it seemed to be that even in your practice, which is universal, it is challenging to have a good grip and understanding of the posterior circulation, either with using SCPs or MEPs. My understanding, just using basic knowledge of physiology and anatomy, is because the rudimentary development of both those parts in difference with the forebrain, which is mainly how we monitor cortex, which is using SCPs. And I followed your answer to the question from Professor Wozniak, how you monitor the spine procedures while it is both the anterior or posterior circulation. Relates into that same, the anatomy and physiology is more rudimentary than the forebrain, which is mainly cortex. Thank you. It's a wonderful, wonderful work that you put together into showing it today with us. So it's great to having had you here. Danke schön, Damen Szeleny.
Professor Kato?
Yeah, thanks so much, Professor Andrea, and it was really a good presentation. Sometimes during the surgery, suddenly disappear the wave. So the surgery is going very well. So how we can realize what happened? So should we sometimes stop the surgery, or should we finish as soon as possible, or tell us, please, something, your idea. Thank you so much.
This
anyway,
is
excellent talk. Thanks.
Yeah, thank you. Well, okay, the sudden disappearance of SCP and MEP is always a high alert, and probably there's a rule of thumb. If it appears very fast, although you probably not really can relate it to the recent surgical step, it's usually very meaningful. In aneurysm case, it's usually pretty easy. So it's in 90% of the cases, we can relate it to a surgical recent step. In tumor surgery, that might be different. We have brain shift, we might have pneumocephalus. So there are all other possibilities why we might see losses, or let's say decrements. And then it's always a communication between the surgical team and us and the anesthetist to figure out what was the reason for the potential loss. So this is why I actually like cerebrovascular cases, because it's usually pretty clear cut that it was surgical related. There are these cases, especially in atherosclerotic aneurysms, where we see the change, and then the surgeon says, oh, it's running very nicely and it's running very well, what you also referred to. And if the SCPs then are lost for good, or the MEPs, we have to admit that probably it was really an atherosclerotic plaque being like an emboli and led into ischemia. Luckily, this is very rare. The other issue is that neuromonitoring is a very technical methodology. So in order to have reliable potentials, and you need training. So when you set up a neuromonitoring in if you set up neuromonitoring in your service, I always recommend to start in cases where you don't need neuromonitoring, so that you can get familiar with each other, that you have situations where the anesthetist can increase anesthesia and you can observe if there are changes, where you are absolutely sure that there can't be any change in neuromonitoring. And if you see some, then you can talk to the team and reconsider why that happened. And this helps very much, especially for the very complex cases where everything should be very specific and very reliable. So yes, if MAPs and SAPs are gone, it's always a difficult decision. I mean, in aneurysm surgery, you try to reopen, to revascularize, to do everything you can do, increase the blood pressure, everything you can think of in order to re-establish the potential. And if that is not successful, it's a difficult decision how to carry on. And yeah, this is in the individual case.
Thanks so much. Thank you.
You're welcome.
Excellent talk. Thanks.
Dr. Sam, you have a question?
Yes, thank you so much, Prof. Andrea. That's a very insightful lecture. I have two questions. First is, I can see that generally most neurosurgeons would put a temporary clip for 5 minutes, rest for 5 minutes. From your experience so far, is there a median time in which the SSCPs and MEPs start to deteriorate or get lost? Is it shorter than 5 minutes? I mean, in my part of the world, MEPs and SSCPs for vascular surgery is not something easily available. So maybe from the data you have, we should cut down the timing, or should we still stick to 5 minutes? That's one. And the other thing, do you see in the near future in which we're going to end up this neurophysiological monitoring is going to be compulsory for all vascular surgeries? How is it in your part of the world? I'm Sam from Malaysia. Yeah.
Yeah, thank you. Thank you for these really very important questions. Well, with temporary clipping, it's the alterations in liver potentials are highly depending on the individual vascular structure and collateralization. So in some patients, you place a temporary clip, and if that is the only patent artery without collateralization, you see immediate changes. And you know that the time is running, and it's running very, very fast. In other cases, you can leave the temporary clip for 20 minutes and you don't see any alteration, as there is enough collateralization. So I'm aware of that. A lot of surgeons use this 5 minutes on off, and I think it's a very empirical approach, and probably need really nice studies to look into and to look if there is really a cutoff. But it's so individual in our individual collateralization that I think the 5 minutes you also have to work, and you have to clip the 5 minutes are not that much of time. So I think 5 minutes are perfect. The other issue is, do we have to use monitoring or not? Clearly, as Dr. Musabelio already pointed out, there are a lot of areas in the world where it's simply not available. I think it's has its value and it's recommended. So if you have a service which can do it, it should be used.
Okay, thank you so much.
Professor Irian, I see your hands raised.
Yes, the conversation moving forward, made me think a couple of practices that I've had back, and that relates with bypass surgery. I hear over and over the cutoff of 5 minutes, and that's fundamental for most cases in vascular surgery. But I want to bring the cases that we see less often than in general, or at least for those colleagues who used to practice by the time that open vascular was more over than endovascular. In bypass cases, I need to remind ourselves that it is not that easy to work around a bypass, even in under skillful hands, in and around 5 minutes. And what I mean by that, and I speak for experiences during my training in Japan, that it requires more than just that. You have prepared your vasculature and you're ready to cut off and create the stamp, and then moving the bypass artery close to where you want to create a new bypass. But the problem is that you will not be able to have it done under 5 minutes, and you would require that to remain so. So what my experience is, what I've seen is within the range of 10 to 12 minutes, which is double that time of 5 minutes, I haven't seen many neuromonitoring changes, and I speak for bypass, which is vascular surgery. Would I recommend colleagues to bear in mind the 5 minutes cutoff? Yes, that's something very important. But what I want to say is that preparations before in such difficult cases requires not only the help of neuromonitoring, but more of us to do some elaborate work in advance to know what we are going to end up. And 10 minutes is usually a better cutoff than just 5 minutes. And if I am to speak for tumors or non-vascular cases, in general, retractions will always, I'm not saying that's a general experience, but in my experience, I've seen always causing ischemia, which in most cases is reversible. And I speak even for practices that I've seen in North America and in additional training. So not necessarily the 5 minute cutoff that we have to bear in mind, because there are cases that would require temporary clipping for longer than that, and we have to bear in mind. And in bypass surgery is always longer than 5 minutes. So Sam, thanks for bringing that question and pointing out the 5 minutes, but as well to Dr. Wozniak to bringing the conversation on the table up front. So thank you very much.
Thank you so much. One last question I would like to ask about the role of MEPs and SCCPs during carotid endarterectomy. What's your experience when we decide about probably usage of the shunt or without shunting doing the endarterectomy, the use and utility in your experience?
Well, basically the same rules apply. So there's data, let's say like that. There's data that you can have isolated MEP alteration. That was published by a German colleague who looked into a multi-center study of MEP changes in CEA, and they looked if they had to implement shunts or not. The majority of the changes are in SEPs, but they're also in a minor group where you see only MEP changes. So I think it's both, as both might happen. SEP and MEP should also be used. So there's also the habit of doing it in awake CA, but well, if the patient can't tolerate, it's extremely useful to have neurophysiology at hand.
Thank you so much. Anyone else has a question from any young neurosurgeons who want to ask Dr. Abele? You want to have, I think your hand is raised. Yes, go ahead.
Yeah. Thank you, Professor. Your talk was very interesting, very informative for everyone, I think. My question is very short. Do you use, maybe it's a little bit out of topic, but do you use neurophysiological monitoring for hemifacial spasm? And also, the second question is, maybe I ask for my for our neurophysiologist. Can we maybe contact you for educational purposes? Thank
Oh
you.
yeah, sure. Yes, sure. So if you're interested, or if one of the other in the auditorium is interested, you can contact me anytime, and I'm very happy to answer questions, or even if you like to come over to have a look. Yes, we do monitor hemifacial spasm and check out for this spreading response, and try. Okay, so the surgeon tries to implement the Teflon pad between the vascular structure pulsating against the trigeminal, the facial nerve, and then to see if the spreading response within the facial muscles is being reduced or stopped. So this is a very other topic. So if you're not really, So yes, you can do monitoring. It's been first described by Möller and Janetta as well for that procedure, and it needs a little bit more hookup prior to the surgery, as we want to see. So the idea is to stimulate the upper or the lower facial branches, and to see a lymphatic spreading. If you, for example, activate the lower facial branch, to see a spreading to the upper facial muscles and stimulating the lower one, and that should resolve during the surgery. Yes, we do that, but we don't have a lot of hemifacial spasm cases in Germany, so it's more or less a rare disease.
I see. Thank you.
You're welcome.
Thank you, everyone. If there are no more questions, I would like to hand it over to Dr. Liu for concluding remarks. We had an excellent session today on vascular neurosurgery. It was a feast, first by Dr. Hirohara and then by Professor Szeleny. I will be handing it over to Dr. Liu for concluding remarks. Thank you.
Thanks, Prof. Ashik-Kumar, for your support always. And we have 2 great lectures today. And also thanks Professor Andrea for introducing IOM to most neurosurgeons. I think it's still very alien to most of us. And we do hope that your center is open to accept fellows, at least to visit. I think I have a system that I think invented from your institution, IOM machine. And I think it will be great experience to visit your center. I think it would be great to hear from Professor Kato for today's session, Professor.
Thank you very much. So the both talk, I think, very highlight at this time, and also especially the vascular surgery, such as the clipping surgery, with almost taking over by endovascular, I think. So the younger generation should have the knowledge and the skill, of course, the clipping and the technique, but also that you should keen to learn about endovascular. So in Japan, we have a endovascular society under the umbrella of the neurosurgical society. So most of the Japanese or most of the Chinese has both a hybrid neurosurgeon. And also the monitor is the most important at this moment, I think. So we had a very nice lecture from the 2 giants, the professors. I really thank you very much, and all the commentators, and also the Ashish. Thank you very much for your excellent MC today. Thank you so much.
Thank you.
Thank you very much. Thank you. Bye.
So, Dr. Liu?
May I ask those who are supposed to attend the meeting to join the panelists? I have invited Professor 𝒂𝒑𝒏. Can you accept invitation, Professor? And for Dr. Kemi, please accept the invitation to join. Dr. Kemi, can you accept the invitation? Yes.
Well, thank you for inviting us. And it's a pleasure to be here. 𝒀𝑵𝒺 is my name from Nigeria.
Can you on your video, Professor? Yes, thank you, Professor. And only we have invited Professor Kazadi. I think I've sent him the new link. I think he's yet to join us. I think probably we can start first, Professor Kato, while waiting for Professor Kazadi, Professor.
Yes, I think so. Professor 𝒀𝑵.
And,
Very nice to see you after a long time.
Yeah, thank you. Nice to see you too.
How are you?
Well, we're fine. We're fine. We've just come out of a fairly interesting and controversial election period in Nigeria, but we're getting back to normal now. And we're happy to be part of this discussion. And thank you for the initiative.
Yes, thanks.
Good
So
to see you.
Yes, yes. So we are planning to have such a North African or Nigeria or your neighbor countries to have some the educational webinar and also the hands-on or live surgery course in the near future. So we want to ask your idea, the timing, and also the contents of the educational webinar. Just let us know, please. 𝒀𝑵, can you hear us?
Okay. Can I go on now?
Yes, I can hear you.
Yes, I can hear you. I hope you can hear
Yes.
me. Can you hear me?
Yes.
Welcome this initiative. We're always delighted to collaborate. And you recall that at the last CANS meeting in